Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher, and today is episode 100. We have been up and running since November 1st, 2017 without fail. Even if we fall on a holiday like Christmas or New Year's, I have an episode for you. I also looked at my listen stats today on Blueberry, and it looks like we are over 80,000 listens now. So thank you for your downloads, your constant support, and the positive messages I receive. I really, really appreciate it. Also, in celebration of my 100th episode, we're going to have a bonus episode this week. So watch your notifications. So if you are a download subscriber, you will get a notification. I'm hoping it drops Thursday or Friday, but you'll get a bonus episode. So yay for the 100th episode. I'm pretty excited about that. So today our CodeCast topic, since it's the last Tuesday of the month, is typically Top 10 Tuesday. But I'm going to reach into my Modifier Spotlight box this week and bring you 3 modifiers that I want to discuss: Modifier 51, Modifier 52, and Modifier 53. These have been really popular spotlights, and we've been getting crazy download numbers for them. And also, my sponsors love the modifiers. So, and I've got a list right now for sponsors trying to get on the show, and I appreciate that. So if anybody does want to sponsor the show or want to get on to have us talk about you, just let me know. Send me an email, terryfletcherccc@gmail.com or terryfletchercpc@aol.com, and more than happy to get you on the show and get you on the list. But we're going to have probably 8 to 10 scenarios in describing some of these modifiers, and so that still sticks with the Top 10 Tuesday. But I just wanted to make sure that the focus was on the modifiers this week. Today's CodeCast is also brought to you by Movado Watch Company, a smart, sleek new design with custom dials, movado.com, and Stranger Things, a Netflix original series, netflix.com/Stranger Things. Okay, so let's start with Modifier 51. So when to use it, when it's appropriate. And you probably use this frequently if your provider is a surgeon, so surgical services. And this is a unique modifier because in regards to where and how it should be appended, it can be a little bit confusing because with the 51 modifier, appropriate coding has to take into consideration the RVUs. So that's the relative value units of the performed CPT code. Otherwise, you're not billing it effectively. So to put this in context or perspective and provide a clearer understanding of 51, I want to give you some understanding of exactly what it does. So Modifier 51 is primarily put to work for physicians who bill surgical services. CPT guidelines explain the 51 modifier should apply when multiple procedures other than E&M services are performed at the same session by the same individual. It says the additional procedures, or services may be identified by appending the modifier 51 to the additional procedure or service codes. So in other words, 51 modifier reports that a physician performed 2 or more surgical services during one treatment session. So the modifier would be applied to any secondary procedures performed. But with the 51 modifier, qualifications for the primary procedure code may be different than what you know about the use of other modifiers. So to report 51 correctly, the coder should list the modifier with the highest RVU. And what that is, the relative value unit. So it means it's not based on how much you charge, it's based on what it's worth. So the RVU is the highest paying, but it's the highest paying, not the highest charged. So that's first. And then you use the 51 modifier on the subsequent services with lower RVUs, the lowest paying, and in descending order. So clarifications on the 51. So example 1, a dermatologist performs an excision of a malignant lesion. During the patient's treatment, a separate skin lesion is discovered, which the physician thinks warrants closer attention. So after obtaining consent from the patient to perform a second procedure, the physician performs a biopsy of the new site. So to correctly and appropriately bill for this, the coder would list the surgical services as follows. Now, this may surprise you. First of all, you would have the wound closure, 12031. Then you would have the excisions. First one, excision of malignant lesion, 11600 with the 51 modifier. And then you would have the biopsy of the skin, single lesion, 11100 with a 51 modifier. But this is a good illustration of where sometimes coding assumptions and the coding rules don't basically mesh. They go their separate ways, because many billing and coding staff would think that the excision should be indicated as the primary procedure because that's why the patient obtained treatment. That's why they came in. But with the 51 modifier being dependent upon procedure cost, we find the closure is the highest valued or highest cost procedure, and that should be billed as primary, with the second and subsequent procedures of the excision and biopsy lower cost, and they need the 51 modifier. When I do audits or practice management, or I go into a practice and assess their billing, I see this mistake all the time. Not with just this scenario, but for example, I'll see a higher valued procedure getting the 51 modifier and the lower valued procedure getting either a 59 or no modifier. And the insurance companies, they will flip it. They will basically pay you how you coded it if it benefits them. So you have to be really cautious about this. Example 2, let's try OB-GYN. So an OB-GYN patient is 10 weeks pregnant and schedules an appointment due to vaginal bleeding. After examination and ultrasound, the physician decides the patient's having a miscarriage and recommends immediate treatment. The patient also requests placement of an IUD at this time. So the OB-GYN performs a surgical completion of the miscarriage and inserts a requested IUD at the visit, which is an intrauterine device. So 51, where is it applicable? So first of all, you have your 58912, incomplete abortion completed surgically. 58300, insertion of IUD, 51 modifier. And then you would have your ultrasound, your 76817. But you just want to make sure you know you're going in descending value order of cost. And then the last one, actually, you can see this in your CPT book, and go back to if you have the professional edition, which is what I use, that is the spiral bound CPT, and I do get mine from AMA. This is one where you can see CPT does try and assist on occasion. They don't always do this, but this can be helpful. So a patient undergoes an arthroscopic rotator cuff repair, so through the scope, not open, with a distal clavicle resection. So it means that they're taking a piece out of the distal clavicle, which is a bone near the shoulder, out. Your rotator cuff repair is 29827, and that's under the scope. But in a parenthetical direction, so in parentheses under this code, it says when an arthroscopic distal clavicle resection is performed at the same setting, use 29824 and append the modifier 51. So I've used this paragraph, I can't tell you how many times, and the page from CPT on denials. It not only instructs what modifiers should be used when both services are performed, but it also then explains to the payer that it's not bundled, and so it should be paid. And so there's a twofold there. And right now, the RAC audits are really, I don't know what they're doing with shoulder surgeries, but they're kind of busting on them, basically saying that shoulder surgeries really should only have the first listed most, highest RVUs coded. And that's incorrect. If you go by the AAOS, American Academy of Orthopedic Surgeon Global Surgery Guidelines and books, you will know that that is not accurate. And so you really need to have all of your ammunition for the payer. And it's really nice when you get parenthetical direction on how to code, how to append a modifier from CPT, because that's an AMA authoritative reference. And so we can say, look, these are the people that create the codes. So you can dispute them if you want, but they're telling us it's not inclusive of each other and this should be billed. Along those lines, as with all things of a provider service billing, it is important that billing staff be proactive and stay informed about billing industry and paying standards and payer standards. Learning and adapting to any changing necessities of modifiers will help. So for example, and this is how you stay ahead of the billing curve, Medicare no longer requires the 51 modifier because their internal systems are programmed to add 51 internally to the correct procedure codes and make the appropriate reductions to the remaining services billed. Many other payers follow suit to the standards of Medicare. So it's evident that with Modifier 51, knowing what payer requirements are there is going to be really important, because your area will be key to appending the 51 correctly. Otherwise, you may see all kinds of denials, because it's really protection, or you'll see reductions where they shouldn't be. Not only does the 51 modifier allow us to code physician services to the highest level of specificity possible, but it also ensures the physician is paid according to that IVU hierarchy. But it's important, again, to stay aware of the current payer guidelines, especially with the 51, how to apply it, your state and local areas, and also with your commercial plans. Otherwise, your revenue is not going to be healthy for your practice. And also sometimes, billers and coders, they can misunderstand modifiers a little bit. And so we just want to make sure that you know when it's bundled, when it's not, when it's appropriate. And it's never appropriate to use a modifier just to get higher reimbursement or to get paid for a procedure that is routinely or otherwise bundled with another code. So we want to use them appropriately and compliantly. So now I want to move on to Modifier 52. And Modifier 52 is outlined for use with surgical and or diagnostic services in CPT. And it says to indicate reduced or eliminated services. So this means that Modifier 52 should be applied to CPTs which represent diagnostic or surgical services that were reduced by the provider by choice. So at first glance, you may think the 52 modifier is similar to the 53 modifier for discontinued services. But even though they are similar in their certain circumstances, they're distinctly different in how they should be correctly used. And these two modifiers in particular, they can cause a lot of confusion. And applying them incorrectly to your claims can not only lead to underpayment or denial, but now you could be dealing with frequency guidelines when it comes to using them inappropriately. So we just want to make sure that you're clear on those. So Modifier 52. So as I noted, the qualifying reduced service codes for 52 are very specific. CPT Appendix A, which are where all the modifiers are, states, quote, under certain circumstances, a service or procedure is partially reduced or eliminated at the physician's discretion. Under these circumstances, the service provided can be identified by its usual procedure number and the addition of Modifier 52, so signifying that the service is reduced. So circumstances for using the 52 would not include a change to the procedure that was unexpected by the provider. So in order to use the 52 appropriately, you need to know why the services were reduced. So this is really important that your physician documents well. And since 52 and 53 are closely related, the why behind what was done will help clarify which one should be used. So an important reminder on the rule with most 52 modifiers: it should not be used when a better CPT exists that describes a scenario you're trying to report with the 52 modifier. So sometimes people will use that instead of having to use an unlisted code or the actual service. So just be aware that you want to make sure you find a code if you can. But if you can't, then this is going to be appropriate. So here are a couple of examples. First one is a provider performs a unilateral tonsillectomy for a 10-year-old patient. So the code 42820, this would need a 52 modifier because that assumes bilateral surgery. And what's interesting is that code doesn't say bilateral in the CPT book. But if you look under it, it has 4 different CPT references saying that, if you look those up, CPT assistant references, saying that this is for bilateral surgery. So to show that it was only performed on one side, a unilateral tonsillectomy, or electively reduced is what we're trying to say here, the 52 modifier would be appropriate to the 42820 code. Another one would be a surgeon performs a laparoscopic procedure for removal of bilateral pelvic lymph glands. The full description of the procedure includes total pelvic lymphadenectomy and periaortic lymph node sample biopsy, single or multiple. And the code is 38572. But the surgeon removes, let's say, all except the internal nodes, iliac nodes. As the doctor elected to stop short of removing the internal iliac nodes, because it says all of them, append the modifier 52, this will alert the reduction in services for this procedure. And so I know it's tough sometimes to know if you should use it, but that would be 2 good examples where there isn't a reduced or a more simpler fee, I guess, a more nominal fee or minimal service. So choosing between 53 for discontinued and 52 is all dependent on the physician's reason, again, for stopping the procedures. So just keep in mind 52 is for reduced services. If you're appending the 52 to a claim, remember to maintain documentation to explain why the procedure was cut short. So this is going to help justify why the payer would have to make a reimbursement decision. So 53 modifier. So now let's look at that. That is to indicate discontinued procedure, so the services. And so this means that it should be applied again to diagnostic or surgical services that were discontinued by the provider. And so this also is a professional physician service, so it doesn't apply to ambulatory surgery centers. ASCs or ambulatory surgery centers would actually end up using a 73 or 74, depending on if anesthesia had started or not. But when you look at these services and really kind of understand the extenuating circumstances, the discontinuation of the procedure is due to unforeseen extenuating circumstances that could threaten the well-being of the patient if the service were to be performed and they went ahead with it. It's similar to 52 for reduced service, but this really means that there was something that happened or that was detrimental to the patient. So this is almost considered the forgotten modifier because a lot of practices and coders just don't know how to use it. And mainly because there's no set definition for extenuating circumstances. So if you're a coder trying to figure this out, it's not your fault. Extenuating circumstances are really left up to interpretation, and it's open to interpretation, so it diminishes its appropriate use. It's especially unfortunate how disused Modifier 53 is, because by not using it, practices can miss out on partial payment for work that was done by getting reimbursed for the expense of surgical or procedural prep. So using this modifier hopefully will explain that's really what it's for. So as noted earlier, qualifying for a discontinued procedure. So 53, CPT specifically says due to extenuating circumstances or those that threaten the well-being of the patient, it may be necessary to indicate that a surgical or diagnostic procedure was started but discontinued, and in this circumstance may be reported by adding the modifier 53 to the procedure. So circumstances would not include a change to the procedure that was planned or expected by the provider. And first and foremost, you need to know why the provider decided to cancel the procedure after it already began. Also note that with the 53, it's after surgical prep or anesthesia is administered. That's why it's discontinued. That indicates the procedure was started in the first place. So a couple of examples on clinical scenarios. So the first one is the patient is seen in an oncology office for treatment of menorrhagia. And so this patient is, the provider attempts to perform a endometrial biopsy. When the provider attempts to perform this biopsy, she's unable to carry it out due to the risk of uterine perforation. So in this scenario, the doctor would bill the 58100 with a 53 modifier to indicate the biopsy was started but aborted because of the threat to the health of the patient. And that's actually a really perfect example for that. Also, CPT has one, and they're pretty specific on this one. Medicare agrees. So a provider starts the procedure for a colonoscopy, but is unable to advance the colonoscope due to proper location because of poor colon prep. The provider bills the 45378 with a 53 to show the procedure was started, but unable to be fully performed due to extenuating circumstances. Now, example 3, I'm going to give you, it came up in a CPT assistant reference, and I don't like it, but I guess I can see why they would put it in there. Remember, you have to document and report everything was done, but this one bothers me. It says a surgeon has a patient under anesthesia and fully prepped to proceed with surgery. However, the physician cuts himself and therefore cannot carry out the procedure. So according to CPT assistant, the modifier 53 may apply to the surgical CPT code to indicate the extenuating circumstances that prevented the procedure from being performed. In this scenario, the surgical prep and anesthesia indicate the procedure had already begun but had to be discontinued. The reason I don't like this, and I'll just put it out there, is that first of all, anything you bill, the patient's going to have a share of cost. And so if there's a complication that is not on the patient, it's something that happened with the physician, I have a hard time submitting that for payment. Also, the other thing I'm having a hard time with is the share of cost for the payment or for the patient. But the big thing that you're going to have an issue with as well is the patient's going to call up yelling at the billing office. But CPT says that's appropriate. So I just want to make sure that you had the information. Otherwise, that could definitely be an issue. So when you would not use 53 to cancel an elective procedure, when it first came out, people were doing that. Coders were basically submitting this code when patient would say, "Oh, I changed my mind about the surgery," and they'd submit it for something that happened, days before they canceled. That's not appropriate. Or discontinued surgeries prior to anesthesia or surgical prep, not for E&M services, and they're not for time-based codes like critical care. So payers are very likely to request supporting documentation for either the 52 or 53 modifier, so that you're going to need detailed documentation on the work that was done. And then notate the following: each step of the procedure you were able to complete, the percentage of the procedure that was performed. So for example, 35% complete, something like that. And then also an explanation of why you were unable to move forward with the procedure. So having that kind of documentation complete and readily available for a payer to review will help you receive as much reimbursement as you can, and in a timely manner where you don't have to figure out what you're actually going to submit to the payer. So make sure that that's ready for the payer if they should ask. Okay, so now let's get to our coding question. And it's an interesting one today. A lot of times patients will come in and they have something called easy bruising. So I have one from one of my clients in Florida, and they said, "Terry, our provider recently mentioned easy bruising in his clinical notes. Is there a specific diagnosis code for easy bruising?" Okay, so this is a symptom, not a diagnosis. So you would report a diagnosis code depending upon whether or not the provider identified the cause. So if the cause is identified, you should look for the code for the specific disease. But if the clinician or provider does not document the cause, look for the code for the symptoms. So if they document easy bruising with no identifiable cause, then you would report R23.3 for spontaneous ecchymosis. So for example, a patient may suffer from a disease such as bone marrow disorder that predisposes that patient to develop bruises, even with a light tap on their feet, or sometimes, somebody will like walk into the counter, walk into a door jamb or something, and they get this easy bruising all of a sudden. And this may not happen to other patients. And so that's what that is for. But a coding tip, the ecchymosis is defined as a bruise that is larger than 1 centimeter, and a bruise that is less than 1 centimeter, but not less than 3 millimeters, is called a purpura. A bruise that is less than 3 millimeters is called a petechiae, Petchiae. And although R23.3 also applies to petechiae, you would not report that for a purpura. So just know that in that area, there's definitely some specifics when it talks about bruising. Today's CodeCast question was brought to you today by XM Radio, Dr. Radio Channel 110. Check it out live and on demand. Download the SiriusXM app today, and you may hear me on the Interventional Cardiology Show, giving my quick coding tips a few times a month during interventional radiology and cardiology, so check it out today. Also, ICD-10monitor.com. On May 25th, the World Health Assembly voted unanimously to adopt the ICD-11, the next edition of the International Classifications of Diseases, January 1st, 2022. So that's the earliest date that member states can begin using ICD-11 for reporting data. So make sure you're checking in with ICD-10monitor.com to keep you up to date on all things diagnoses. So I'm going to end today with my personal tidbit, and it's with a quote that I saw on social media that I thought was perfect. And it says, "Never blame anyone in your life. Good people give you happiness, bad people give you experience, worst people give you a lesson, and the best people give you memories." So that's just my thoughts for today on this Terry Tuesday. And so that's it for me today, guys. Make it a great day, make it a great week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.